ELI Chapter 14, Nutrition and Hydration. For the aging, the effects because of aging, the common effects, decreased need for calories. They're not having as many activities in general. We can't assume that, but we need to find that out. Possibly their metabolism is decreased. Other things are a high prevalence of tooth loss, the decreased saliva production. It's possible that their digestion system is inefficient. They can tend to have esophageal issues, weakened, decreased esophageal peristalsis, lower tolerance for a lot of different foods, acidic foods, especially if they've had a long history of GERD, esophageal reflux, and then also less efficient cholesterol stabilization, absorption. I'm taking these off of the nursing diagnosis table 14.1 on page 173. It gives you a lot of examples of the possible changes that can occur with the aging process. So remember that all of these common changes all depends on the unique individual. This could be present, and it all depends on their own activity level, their diets, and how they've lived their entire life. One of the most important questions or items to consider are quantity. How much food do they need? How much nutrients do they need? Versus quality. The type of food that they're actually taking in. How much do they need? And then what's the quality of the food that they're actually taking in? What will best meet their nutritional needs? There is a Harris-Benedict formula that will determine resting energy expenditure. It's also on page 173. It also takes into account their aging, the possible aging changes. It indicates the current calorie need to maintain their body weight without taking into consideration exercise expenditure. This is kind of what is used for persons with chronic conditions and without a whole lot of activity, more like a sedentary lifestyle. And dietitians are awesome resources to help figure this all out, like what the patient's used to eating, and now that they're having to go into therapy and have 3 hours a day of therapy, what kind of intake are they going to need to help meet their energy expenditures? Or if they're not moving at all, but they're getting tube feedings, gastrostomy tube feedings for their nutritional source, how much calories do they need if they're not burning calories off, if they're not up and moving, if they've had a stroke and they're limited, how many calories do they really need to maintain the current body weight that they have? So let's talk about the quality of their intake to be considered. There's a recommendations on table 14.2, page 174. For example, their dietary fat is to be less than 30% of their total calorie intake. Their protein should be 10 to 20% of their total dietary intake. 1 gram of protein for every kilogram that they weigh. So if they were to weigh 15 kilograms, then they would get 15 grams of protein. Fiber, it's recommended 20 to 35 grams in a 24-hour period. However, it's really interesting how many people really get that. And I've also seen some recent research to where it's more like 25 to 30 because it depends on what they're eating. And so many people are eating shakes and things like that have, good nutrients that have a lot of fiber in it. And it's natural and uncooked. So they get a lot of the protein value. And we're talking about the soluble fibers, oats, items with pectin in it. Pectin is in low-carb veggies such as cucumbers, white mushrooms, broccoli, RAAB, R-A-A-B, don't ask me what that is, helps to decrease the cholesterol and promotes great bowel activity. Good bowel formation as well as peristalsis. because it triggers fluid. If when someone isn't taking they don't have fiber at a good regimen level, they need to increase their fiber slowly, not all at once. For example, if someone is going to need to be taking something like Metamucil or increase their bran, increase their things that can really bloat them quick. But if they do it too fast, it can bloat them really quick and really, really cause pain and problems. It can be very uncomfortable. So it needs to be done slowly. For example, if I was to increase Metamucil on somebody, I would do like 1 teaspoon or a third of a teaspoon, like for 3 days, and then increase it to 3 times a day for 3 days, and then increase it to 2 teaspoons or something like that. But we'd have to go really slow and really careful. And then when you give them the Metamucil or Citracel or whatever, lots of water needs to be drank. And even with our natural sources of fibers, water. Supplements. Please note that different areas of the text mentions different supplements. Supplements, especially for our aging persons, really should be in divided doses. Divided doses that this will assist them with the absorption. For example, calcium, 600 milligrams twice a day with food. If we give them all 1,200 milligrams at one time, you have to wonder how much they're going to actually digest and absorb and distribute. So we always have to remember those concepts from the pharmacodynamics. We need to make sure that they're not taking more than the recommended. Discover what they're using at home, what their at-home list is. This is that whole concept of medication reconciliation, and remembering that supplements are a portion of quote-unquote medications. The different vitamins to consider, A, C, D, B complex, including 3, 6, and 12, folate, calcium, potassium. Potassium is a really big deal. So many patients are out there regulating their own Lasix, and then they're not adjusting their potassium because there's not really an easy guideline to give them. If you're telling them take 1 pill or 2 pills, if you gain this much weight, take 1 pill. If you take this much weight, 2 pills. A lot of times to also explain, okay, but increase your potassium this to this. If you've done it for 3 days in a row, it would just be way too complicated. But it gets ignored, and so a lot of times patients will have hypokalemia because of that when they come into the hospital. Hydration, fluids, water. According to the IOM report, the Institute of Medicine from several years back, adult men should have 3.7 liters of fluid in a 24-hour period, and women should have 2.7 liters of fluid in a 24-hour period. What are the risks of decreased fluid intake? Well, remember that our elderly clients, or patients, a lot of times they have a reduced sense of need. They have a decreased thirst sensation. They also will decrease their own amount of fluid intake because of fear of incontinence. Or a fear of embarrassment when they go out. My mother will not, when she comes over to my house to visit, she will not have fluids with her meals. And so she won't eat much because a lot of our elderly, because of their esophagus and because of the decreased saliva, they drink fluids with their meals. They're many times taught to take a drink before they eat and chew food, and then take a drink after for swallowing, especially with the decreased peristalsis of the esophagus. There's also, a lot of times cold water or water can cause, for some people, GI distress, nausea, believe it or not. So if they come into the hospital and they're having dehydration, it's really important that we're careful about how we hydrate them and how fast we hydrate them. Because we can overhydrate them too fast. Because remember, their bodies are not going to their body possibly may not distribute the fluids as fast as they need to be. And so if that happens, it's going to pretty much go straight to the lungs. And so we need to always listen to their lungs. We also need to watch the vascular system. Because again, if the vascular system is weak, it may not distribute as well, and therefore they can become hypervolemic. So we have to monitor the cardiopulmonary system as well as the kidneys together. We're watching the kidneys because we're watching the BU and the creatinine, but then we also need to assess the cardiopulmonary system. Let's chat about oral health. Dental care must include flossing. One of my pet peeves, I have a lot, I know, but one of my pet peeves is when I see patients who they brush their teeth, but then they have all this gunk in between their teeth, and it's because nobody ever flosses. It's important that we floss because they can end up with periodontal disease a lot. It's not normal for them to lose teeth, but they will lose teeth when they're not taken care of. I hope that makes sense. Typically, if they are losing dental teeth, there's a high prevalence of dental loss, but typically that's because of how their teeth have been taken care of their whole entire life. The numbers of persons taking better care of their teeth is growing, and which is much better because that has almost everything to do with their nutritional intake. So considering what are a lot of persons will think that with dentures that persons don't need oral care or an oral assessment. That's not true. The dentures must come out and we must assess. I actually had a patient at one time who had dentures and they were brand new, and he ended up going to the hospital with a heart condition or something. I can't even remember, but everybody kept saying, he's a big man, he's lost a lot of weight, we don't understand why is he losing so much weight, and there was so much going on with his condition that nobody paid attention to his eating, and he wasn't eating very much, and basically he got across, and he had mild dementia, and basically he got across finally that his mouth was hurting and it was in pain, and we popped the dentures out, but he couldn't get them out. We had to actually soak them and really put some spray some saline in there and some cool water in there to try to get them out, and then we started tugging on them, had to get them pain pills before we could start taking them out. And lo and behold, because when people start wearing new dentures, they're supposed to get their body used to them, and they come in a few times for the dentist to, size them and make sure that there's no pressure areas or pressure marks on especially the palate, the soft and hard palate areas. Well, he actually had a wound behind the hard palate on the soft palate, right where they meet each other. And it was bad. It was like really, really, really bad. But anyway, so an oral surgeon had to come in and give treatment for it. He couldn't wear dentures for quite some time, so needless to say, he lost a little bit more weight because he refused to have a gastrostomy tube even for a short period of time. So a lot of his food was liquid. So we can't forget to assess that mouth. With weight loss, we have to take into consideration that dentures may not always fit correctly. And so they could slide around and cause sores. The dentist can fix this, but they have to know that there's problems, and so then they have to be contacted. So periodontal disease symptoms: easily bleeding gums, an odor that doesn't smell very good. A lot of people say that it kind of smells like poo. Inflamed, tender, bleeding when we use soft toothbrushes even. Loosening of the teeth from the gum line. Many times we hear that if it's bad breath, to consider the lungs. However, we need to also remember that it could be just the teeth or the oral pharynx. We should not be using alcohol mouthwash. This can tend to dry out the gums and the tongue and affect their taste, so we need to be careful. There are some special mouthwashes that can be used, especially if they start to have sores and things like that in their mouth. ACT or ACT and Biotine are two of them. The other thing to consider with the mouth and oral care is to consider sores. When they tell you that they have a sore, to continually look at it, make sure it's documented, and if it's a non-healing sore, a lot of times it's going to be cancer. I had a patient who had cancer of the lungs, and she also had cancer in her mouth and her tongue, and I had sent her out to an oral surgeon first, and they just put medicine on it, but it was there for weeks. It was there probably for 2, 3, 4 months, and it wasn't really getting any bigger, but it wasn't getting any smaller, and it wasn't healing. It's on the tongue. A lot of people say that the mouth is one of the fastest healing parts of the body when there's a sore or a canker sore or whatever. So anyway, then they discovered that she actually had cancer in her tongue as well. Nutritional threats. Get the details. What is the patient's usual weight? What is their weight history? How long have they been at their current weight? Is this new? Is it chronic? Many times the patients share that they can't eat the large meals provided in facilities or in hospitals. If at all possible, it's recommended that they have small, frequent meals. For example, 6 per day versus the 3 big meals. Another one of my pet peeves is we make them eat these great big meals that they're not used to eating when they're at home, and then we say, oh, well, they only are eating 50% of their meal, instead of saying, okay, this is how much they're eating and this is how much calories and stuff they're getting from what they're eating, and likely it's probably enough, especially when they're eating these type of snacks in between their meals, blah, blah, blah. So we have to find the cause for their weight loss, understand what it is. Is it because they've had recent surgeries, for example, anesthesia? Have they had certain treatments? Have they had chemo recently? Have they had radiation recently? Have they had their medications changed recently? So differentiate between anorexia and cachexia. Anorexia, loss of appetite, no desire to eat. Cachexia is when their weight loss is greater than the body should have within a certain amount of time. For example, losing 10 to 15 pounds in 1 week, and it becomes very noticeable, and their skin is sunken in, especially at the clavicle area. It becomes really noticeable, and sometimes their cheeks. So understand the difference and try to figure out the why. Dysphagia, ask questions, get the details. For example, does their nose drain more when they eat? What happens is that if they have problems with swallowing, if they have dysphagia, problems with swallowing, then the food the bolus after they chew it up, tends to get lodged in the back of the oral pharynx, and think about where the location of the sinuses are. So if the food goes up too high, then it can trigger responses from the sinuses and nasal drainage. So it's really important that we ask those questions. We get the details. What diagnoses do they have? What other conditions do they have? Parkinson's, GERD. Also asking about their swallowing. A lot of times if they eat certain things, the foods may get stuck in the chest, or it feels like it's getting stuck in the chest. Same thing with hiatal hernias. A lot of times if they have a hiatal hernia, unless it's causing a lot of problems, decreased eating and things like that, then a lot of times they won't treat it. We'll just treat the responses and the reactions, like that's more on the GI, so let's cover it there, I'm sorry. But we need to make sure that we understand what's going on with their GI tract, the whole system, in regards to nutrition. Constipation we'll cover more in chapter 21, but I think you all know about mobility and water and fluids, fiber, and increasing it slowly. There is a mixture: 1 cup of bran, 1 cup of applesauce, 1 cup of prune juice. Keep it in the fridge, mix it all together, keep it in the fridge, and start giving a teaspoon in the morning and at lunch and at dinner, and then increase as able. But that can really help regulate their bowels. Malnutrition, their appearance can be deceiving because of the gravity and the elasticity decrease of the skin. If weight loss of 5% in 30 days, make sure that we're asking the questions of fluid loss. Have they been with their primary doctor? Do they have heart failure, pulmonary hypertension? Have they had a lot of fluid pulled off at any given time in the past 30 days, and maybe that's why they've had a decline? It's funny, a lot of times patients will have their edema for a long time, and that could be an actual 10 pounds. And they lose it, and that could actually be 10% of their body weight, especially if they're a small, petite little lady. The percent is said to be of ideal, or the usual, consistent weight, the usual consistent weight of 6 months to 1 year, of where the patient wants their weight to be. We need to make sure that we are monitoring the prealbumin, and that the prealbumin is appropriate. The prealbumin is the taking in of the protein currently, like the last 72 hours, 48 hours. But the albumin is telling us what the protein has been over a couple week time span. So that will tell us if they are protein calorie malnourished. So remember what the difference between the prealbumin and the albumin indicates. Review the assessment on page 182 for the nutritional status. Are you surprised? Have them keep a diary, a log of intake. This can help the providers a lot of times figure out what they can do to best educate them, or even you as nurses to best educate them on the things that they need. What should they eat the most of? Do they have wounds where protein is needed? That if they don't eat very much, then at least choose to eat the protein first. Do they have end-stage COPD and or Huntington's? Well, then maybe they need a high calorie, high protein. So divide that in half and make sure that the calories, that the high carbohydrate items that they're getting for their calories are the good carbs and protein. So this also will help them find out what community resources might be available to them and what their needs are. So when you're doing the physical, it's also really important to look at a lot of people talk about iron deficiencies and B12 deficiencies, and they mention the beefy red tongue and things like that. So here's the thing. For tongue soreness and beefy red, then typically it's a B12 deficiency. And also when there's like cracks in the side of the mouth, a lot of times that's also a B12 deficiency. Iron, a lot of times they will also have the beefy red tongue, but typically their tongue feels rough, and sometimes it gets enlarged. So a lot of times, honestly, if I can't really define which is which, ask the providers for a drug test. I'm sorry. Ask the providers for ask the providers for an iron test. First a CBC with a dip, because those indices can tell if it's iron or not, if it's an iron deficiency. And then you may have to go deeper into more iron specific tests. But then they can also test specifically for B12. So to recap, the biggest thing is make sure that we understand the common changes with the aging, chronic conditions that are occurring, and how any of those chronic conditions may have any connection with nutrition and hydration.